Are we recording now? Okay.
We are now live.
Great, thank you. I'm glad to see everyone. So we'll get started. I have one follow-up to an announcement that was made at the last meeting regarding the CDT code increase with the approximately $20 million that was allocated. So effective July 1, 2022, there will be 32 CDT codes that will have rate increase at the rate of 9.5%. So this decision was made with a group of stakeholders, practitioners around the state. Several of the members of the task force were involved. There were 3 meetings to decide, and it was decided that these codes, ones that are most utilized, there was an analysis made, and that these were the 32 codes most utilized. And with this increase, it would be more of an incentive for new members, new practitioners to join, and to keep those that are currently participating with Maryland Healthy Smiles involved. So does anyone have any questions about that? Yes, I see. Delegate Bagnell, you have your hand up? No?
I did have a question. For,
no, I don't know. Okay, sure. Who has a question?
2350. I mean, I'm sorry, for 2750 for a crown, what will it be? Because it's anemic right now.
I do not have the list of the 32 codes in front of me with those costs, but we can certainly send that out.
That would be great. If I could.
Okay.
Okay. And I thought it was January.
And this is Nancy from.
It's not January 1. It's, you're saying next. You said
no, so these are just specific codes that are allocated to that additional money. January 1st will begin the new benefit for adults. That's when it's scheduled to begin, January 1.
I understand. Thank you.
Certainly. Any other questions? So we're delighted to have a number of speakers today. We're going to be discussing dental therapy, and we're also going to have a presentation from our subcommittee on the elderly. What I'd like to do is introduce our speakers. We will give Dr. Grover a moment, and so we will begin with Dr. Kamal and then proceed in order. So a brief bio on our speakers. Dr. Jane Grover is the Director of the Council on Access Prevention and Interprofessional Relations at the American Dental Association. Dr. Grover has worked in private practice as a general dentist and has served as Dental Director of the Jackson County Health Department in Michigan, as ADA Vice President and as adjunct faculty at the University of Michigan School of Dentistry and Lutheran Medical Center of New York. Dr. Prasida Kanal is the State Oral Health Director at the Minnesota Department of Health. She was trained as a dentist in Nepal and practiced as a community dentist in Nepal, mostly serving in rural areas. Dr. Kanal completed the dental public health residency at the Eastman Institute for Oral Health, University of Rochester, New York, and has served as adjunct faculty at St. Catherine University in St. Paul, Minnesota, and at the University of Minnesota School of Dentistry. Dr. Kanal is joined by Natika Moibai, Supervisor of the Office of Rural Health and Primary Care at the Minnesota Department of Health. Last, we have Dr. Carl Self, who is an associate professor at the University of Minnesota School of Dentistry and director of the Division of Dental Therapy. Dr. Self holds both a DDS degree from the University of Minnesota's School of Dentistry and an MBA from the University of Minnesota's Carlson School of Management. Dr. Self has worked in both private practice and large group practice, but has spent most of his professional life in a community clinic and serves on the board of a number of nonprofit dental-focused organizations. So I'd like to take this opportunity now to turn it over to Dr. Kanal. Thank you so much.
So Nitika, do you want to?
Should we go first? Okay, I wasn't sure if we were waiting for Dr. Grover or not. So good afternoon, everyone. My name is Nitika Moabi. I'm with the State Health Department, as I was just introduced, and I'm going to be kicking off our Minnesota presentation. We did have a chance to loosely coordinate our conversation right before this, and so I'll give a brief overview of the dental therapy experience in Minnesota, and then I'll hand it over to Dr. Carl Self, and he'll provide a little bit more about some of the research around the effectiveness of dental therapists in the state, and then I'll hand it off to Prashida, and she'll help talk about some of the more current research that's going on around dental therapy. So could you please let me know if you can see my screen? I'm hoping that you can. Yep, great. Okay.
Yes.
So this is just some brief history in Minnesota looking back. Our conversation around dental therapy really started in 2008 when there was a work group that was chartered by our legislative members. And part of that was an international site visit to New Zealand, where some of the early enthusiasts got together to understand how dental therapy works in New Zealand. And the impetus for this work group was really the coming together of the oral health safety net community members and advocates and education programs in response to some really long-standing oral health disparities in the state and the access constraints that we have in Minnesota. We also have in this backdrop an aging dental workforce, historically low reimbursement rates for dental procedures, and a fairly low participation of dentists and Medicaid. So all of these factors kind of came together and congealed into a work group that was chartered to look at dental therapy. In 2009, our licensing laws first passed and education started to begin for dental therapy. In 2011, we graduated our first dental therapist who started practicing in our state, and she was licensed. In 2013, we certified our first advanced dental therapists. And Dr. Carl will talk a little bit more about dental therapists and advanced dental therapists, but I'll just use the term dental therapy more globally to mean both DTs and ADTs for the sake of our presentation. In 2013, our Medicaid agency also started to enroll dental therapists as a billable provider. And I think one of the key decisions that ensured sort of the success and the launch of dental therapists was the Medicaid agency's decision to reimburse dentists at the same rate as a dental therapist for the procedures that the dental therapist provided and conducted. In 2014, we had our first state evaluation of dental therapy impact that was headed by the Department of Health. And in 2016, we've had some more recent changes to the education requirements, and they're now a master's level program in our state and have a dental hygiene preparation prior to receiving a master's degree. So I want to talk just briefly about the launching pad and what it's taken to get us to where we are today. As I said, we have 3 education programs in our state that prepare dental therapists. The University of Minnesota that Dr. Carl Self represents, Metropolitan State University, and Minnesota State Mankato. These are the 3 sites that are educating dental therapists. We have the Board of Dentistry that does the licensing and the regulation of this provider type. And our dental programs are currently operating under the authority of the Board of Dentistry because we're still awaiting CODA accreditation. Our Department of Human Services, which is our Medicaid agency, played a pivotal role, as I just noted about, to enroll them as a billable provider and to reimburse them at the same level as dentists. The Department of Health that Rashida and I represent, we played a key role, we think, in just doing some ongoing workforce tracking of dental therapists. We did the first evaluation of the effectiveness and the impact of dental therapy. Are involved in sort of monitoring their success, developed an employer toolkit, loan forgiveness programs, sort of all of the ingredients that are necessary to launch this new provider type. There also is a dental therapy association in the state. It's fairly young, but there are a group that is organizing and getting together. And we also have a unique multi-sector coalition, which we call the Minnesota Dental Therapy Research Stakeholder Group. And this comprises of education programs, employers, state agencies, including the Department of Health and our Medicaid agency, researchers who are interested in oral health workforce issues and access, et cetera. I want to briefly just talk about some enabling factors. I'm not entirely sure where Maryland is in their journey to dental therapy, but some of the things that we thought of as we were launching this work is sort of being clear about an identified need and why, sort of the business case for dental therapy and the role that the advocates played in dental therapy education, and making sure that there's a defined scope of practice that's regulated. The programs are accredited. The legal protections and liability issues are thought through and in place. Credentialing and reimbursement is an issue, and then how do you integrate them into everyday practice, and how are they professionally accepted into their profession? And this is a an innovation adoption curve, and I share this to say that some of the ingredients we thought through to help with the uptake of dental therapy in Minnesota were what are the things that the early adopters would need to know, or some of the visionaries, and what are some pragmatic things that the early majority would need to know, and what are some convincing arguments that some of the conservatives of the late majority will need to know. And there will likely always be a share of population that will not buy into the concept of dental therapy and will be skeptic and kind of lag in the adoption of the phenomenon. And to ease some of that, we undertook efforts such as producing an early employer toolkit, sort of the how do you integrate a dental therapist who has a hygiene background into your work setting? How do they get credentialed? How should we think about liability for them? Because there's no history of claims from dental therapy in the nation, really. We also published our first evaluation that looked at the impact on access for some of the early adopters. What impact were dental therapists having in their patient population, in wait times and travel distances? What were patient satisfaction surveys telling us for patients who had seen dental therapists? Were there any complaints at the board about the practice and the safety of dental therapy? So these are just some considerations we needed to think through. And then in 2014, we published our early impacts study that is available or can be requested on our website. And these are just a couple of links to some of the work that I just mentioned. And now I'll hand off to Dr. Carl Self, and he'll go over sort of the history from an educational perspective of dental therapists and the impact and the effectiveness from the research. So thank you. And I'll stop sharing here.
Thank you, Nitika. And if we can pull up my presentation. So again, Carl Self, I'm the director of the dental therapy program here in Minnesota. And so I've been involved with it since the beginning, after the legislation was passed. And I'm really excited to be able to share a bit about our experience. We're really proud of what's been done in Minnesota. I usually give presentations of 1 to 3 hours in length, and I know I don't have anywhere close to that here today, so I'm going to try and squeeze in things in 5 to 10 minutes. Hopefully, you'll get the gist of it, but I'm certainly will be open for questions afterwards. Next slide, please. So I think it's really important for everyone to understand that a dental therapist is not an independent practitioner. The dental therapist is a part of a team. They play a role similar to a physician assistant in a medical setting. They are complementary to dentists. This really isn't about competition, somebody taking somebody else's patients. A dental therapist really extends the reach of a dental practice, and the purpose of it is to allow the practice to see more patients, and in particular, more patients who are underserved and currently having difficulty accessing care. Next. And so when we ask, how do we know they're meeting the needs of underserved patients? Well, our Minnesota statute requires that dental therapists practice in areas that are limited settings, that are in areas that serve low-income, uninsured, underserved patients, or in a dental health professional shortage area. And at the time that the legislation was passed, Minnesota had somewhere in the neighborhood of like 75% of the counties, I think, were health professional shortage areas, maybe a little less, but very significant. Next. So again, the dental therapist practices under the supervision of a dentist. And it was alluded to that there are two types or two levels of dental therapy in Minnesota. When you graduate from an educational program, you get licensed as a dental therapist. And as a licensed dental therapist, you can do your preventive kinds of procedures, non-invasive things. Most of that is performed under general supervision, which means the dentist does not have to be in the office while you're performing it. They have delegated that procedure. They know what you're doing, but they don't need to be in the office. For a licensed dental therapist in the state of Minnesota, if you're doing restorative care, extractions of primary teeth, more invasive kinds of procedures, that is done under indirect supervision, which again, the dentist has delegated, but requires the dentist to be in the office. Next. And so once you're a licensed dental therapist, assuming you've had a certain level of educational training, and in Minnesota, it has to be at a master's level, and you've had 2,000 hours of practice as a licensed dental therapist, you can go through a certification process to become an advanced dental therapist. Once you're an advanced dental therapist, you can do your full scope of practice under general supervision. So the value of that is allows dental therapists to go into schools, into community settings, satellite sites in rural areas, and perform their full scope of practice without a dentist being physically present in that office. As an advanced dental therapist, you also have the ability to do a few more procedures, including the oral evaluation and assessment, which really translates into an exam. And there's certain exams that are authorized, and you can formulate that treatment plan that the collaborating dentist approves. And you can also do some extractions on permanent teeth, generally very mobile teeth that have had periodontal disease. Next. So when you talk about the dentist collaborating with the dental therapist and the general supervision, people often ask, well, how do you monitor that supervision? How do we know they're doing what they're supposed to do? Well, again, our statute requires our dentists and dental therapists to have something called a collaborative management agreement. In Minnesota, we call it a CMA for short. And that CMA is really, it's a contract. It talks about how they're going to work together. There are certain components that have to be addressed, including what's the practice setting and the populations the therapists are serving. Are there any limitations to the services they're providing? What happens as a plan for managing medical emergencies? What is the quality assurance plan, and monitoring the care? How do the dental therapists work with the dental assistants, and how do they supervise them if the dentist isn't present? And things like what happens if they run into things outside of their scope of practice, and the need for referrals. So it's a very comprehensive document. It needs to be filed with the Board of Dentistry, and it needs to be signed and updated every year. So that's whether you're a licensed dental therapist or a certified advanced dental therapist. And again, our statutes limit the number of CMAs that a dentist can have to 5 at one time. That was because there were concerns that a dentist might hire, 20 dental therapists and not do adequate supervision. Next. And so, where are we today? Well, as of April, there was 120 licensed dental therapists in the state. We do at the University of Minnesota go through those CMA documents a couple of times a year to see where folks are and what they're doing. It's not a surprise that the nonprofit clinics and the FQHCs, who were the first group of employers to hire dental therapists. They were the advocates for it. And so they had the early advantage in hiring dental therapists. Now we see that small private practices, which we define as less than 5 dentists, and large group private practices, they employ 58% of our dental therapists. It's started to pick up as dentists understood the value that this brought to their practice and the ability to allow them to see more government programs patients and do it in an economical way. These numbers are changing. There were 14 graduates in May coming out of the various programs. We don't have that updated data, but we do know that employment for dental therapy in Minnesota is at what I call full employment. We have more employers looking to hire dental therapists than we have available dental therapists. And in June, every month, we look at ads to look for employment. There were 15 offices looking for dental therapists. And to the best of our knowledge, there might be 2 who are unemployed, and that's by choice. Next. To get a quick look at where they are in the state, this map, the grayish area is our 7-county metropolitan area. People talk about the fact that there's a lot of dental therapists there. Yeah, roughly 63% of our dental therapists are practicing in the metro area, but that reflects the fact that 60% of our population is in the 7-county metropolitan area. And so we have 37% out in what we call greater Minnesota, outside of that metro area. And you can see by the dots on the map that they are spread out throughout the state. We have a lot of therapists in various communities in all parts of the state of Minnesota. And these are just fixed sites. This does not include mobile, school-based, other efforts where we have therapists whose home base is in the city, and they may go out into a rural area on a day-by-day basis or on a week basis in order to provide some additional care to underserved populations. Next. And so Nitika mentioned the fact that there was that early report to the legislature. And, that early impact report talked about a number of different things that were happening, in dental therapy in the state. Well, since that report, there's been 8 external case studies, 2 peer-reviewed journal articles that talk about implementation in some way, shape, or form. And I've had the opportunity to go out and visit a significant percentage of things in the state. Next, please. And so if you look at it and summarize all of these, I won't go into the details of each one of those reports, but they're consistent, and they're consistently finding that wait times for appointments for those on Medicaid have decreased, that and the visits are increasing in the clinics that employ dental therapists. We see that a number of studies have shown that the percentage of Medicaid patients in a dental therapist's schedule, it's typically in the 60 to 80%. Now, that's not all, obviously, But what makes this something different and than just adding another provider to a clinic is the fact that the dental therapists are focusing on doing fillings, and they're often seeing many of the kids in a practice. And when you focus on anything, you not only get better at it, but you get faster at it. And so the dental therapist schedules are more efficient, and they're a lower cost provider doing procedures that, quite frankly, bring in lower reimbursement. And the dentists can now spend their time doing root canals, doing more implants, more complex surgical procedures, and full mouth rehabilitation, because they're not interrupting their schedule with these short appointments. That allows, in particular in rural areas, patients to be seen who traditionally have been referred to other places. So patient satisfaction is higher. And those procedures typically bring in higher reimbursement. And so total net revenue for these clinics are going up as well. Next. So that in a nutshell is kind of our experience, with what we're seeing about the impacts and the implementation of dental therapy. And so I'll take questions when questions are available, but I'll turn it over to Prashina now.
Yes. Nitika, do you mind sharing the screen, please? Yes, thank you. Good afternoon, everyone. Once again, I'm Prashida. I'm the State Oral Health Director at Minnesota Department of Health. Thank you so much for having our team here today. Today, I'm going to talk about a research project that was conducted by our Dental Therapy Research Stakeholders Group, a group that was convened by Minnesota Department of Health with the aim to increase the knowledge and awareness about dental therapists in general. This group has also been serving as expert group to inform the national efforts. So the dental therapy research group considered different ways in which dental therapists can actually increase access to dental care, and also looked at strategies to drive down consumer cost while still ensuring safe and effective care. But for us to move in that direction, the first step was to actually better understand the reach and impact of dental therapists in Minnesota. So the group wanted to look at minimal data sets or feasible data elements that could be easily collected in standard ways across a variety of clinics that were using different dental clinic management IT platform or different kinds of dental software. So what we did was we basically recruited 4 dental clinics that were actually hiring dental therapists across the state of Minnesota. And then what we found, so we basically used a RedCap survey to conduct the assessment, but each clinic used the electronic health system to pull the data that we wanted to look at, because we were trying to move towards minimal data set direction. So what we found from the study was, Nitika, if you could scroll up a little bit, please. Thank you. So as you can see on my slide, so at that time, so the data is reflective of the calendar year 2018. So it looked like we had 92 licensed dental therapists in the state. And the interesting part was that 25% of these dental therapists were employed by 4 of our partner clinics. And it was very evident that approximately 31,000 patient visits were provided by dental therapists at the pilot practices. And around 1,793 were the average visits for dental therapists working all 12 months. And 14 out of 23 dental therapists were advanced dental therapists who were more eligible to go out in the communities, as Dr. Self was mentioning earlier, at least 12 months of employment during project period. And then around approximately 2,000 average visits were there for advanced dental therapists working all 12 months. So Nika, if you can go back to the normal view so I can talk about Yes. So we did look at the CDT categories because we wanted to look at the procedures, because at this time, our research group wanted to know what dental therapists were doing. So if you look at the slide, you can see the breakdown of the procedures performed by the dentist on your left versus the procedures performed by dental therapists. And you can see a variety of categories of procedures from diagnostic, restorative, to all the way to perio and orthodontic. So you can see that in both the categories, I think diagnostic services were provided mostly by both the providers. And then you can see that dentists are still doing more restorative than dental therapists, but some of these differences are really because of the obvious reasons that dentists would have more scope of practice for oral surgery, orthos, or more like endodontic procedures. So this was more of our local level work, but the way we want to use this data today is to actually give you the bigger picture. So if you look at the map that's on my slide, Nika, if you can go a little bit, scroll up. So I got this map from one of the resources. So it really nicely shows some of the states that have been considering dental therapy as their legislative initiative. And I feel like Maryland is probably in that journey too. So as Minnesota is embarking on this journey to understand what our dental therapists are doing, what is the reach and impact, it's very important for us to share our lessons. And every time I go to conferences or I meet with my colleagues from other states, especially if they are considering dental therapy in their state, I do get 4 big questions. And today I'm trying to answer those 4 questions based on the pilot we did. So the first question is, Nitka, maybe you can stay with the standard view so I can go back and forth between the, yes, thank you. So the first question is really about where are the therapists located geographically, which is something that Dr. Self also talked about. So based on his recent data, we have 120 dental therapists in the state. And yes, it is correct that initially our dental therapists were located in the Twin Cities, because if you look at our 4 major pilot clinics who employ dental therapists, they are in Twin Cities, which also reflects the kind of underserved population, how they are more located in the Twin Cities. But if you look at this map again, it shows the distribution of dental therapists all across the state. So from the initial phase of being more in Twin Cities, now that you see them going all across the state. So it answers first question, where are the dental therapists located geographically? But then more than rural urban differences, it's important to understand that in Minnesota, our statute requires our dental therapists to work in a setting that offers services to underserved or low income patients. So more than the only looking at urban or rural distribution, it's important for us to understand that there are pockets of population that are still underserved even within the Twin Cities area. So that is the reason why you see more clinics and more dental therapists working in that area. The second question is generally about what percentage of the patients are Medicaid. So our study indicated that 75 to 95% of patients were in public assistance, which actually meets the objectives of why we had advocated for dental therapists in the first place. And rest of the patients were uninsured or underinsured. So third question that we generally get is, our dental therapists in direct competition with private practice dentists, which I think Dr. Self also talked about a little bit, that there is a collaborative management agreement, even in a brick and mortar kind of a clinic, where I, as a dentist, know exactly what my dental therapist is going to do. So we decide our procedure, so we know exactly what we are doing. So that, I think, is beautifully done in Minnesota. And I feel like those kind of language is so important as we are considering team-based approach for increasing access to care. And yes, the level of supervision is different. So from dental therapists to becoming advanced dental therapists, the supervision keeps changing, but there is absolutely collaboration and there is no competition. So what is the next question is actually about the increased profit margin for private practice dentists that have hired therapists, like what is the business case? So I think I will go back to the breakdown of the CDT categories, where you can easily see that if dentists are delegating more of restorative procedures or more simpler procedures to our dental therapists, like Dr. Self said earlier, they can actually focus on more complex procedures. And in Minnesota, the beauty of our statute is that the reimbursement is by procedures, not provider type. So we did not only start dental therapy, but I think the way our policies are written, or like the policies are, it's really supportive of different kinds of innovative workforce model, where if a dental therapist is performing class 1 restoration, the reimbursement is same, whether it's a dental therapist doing it or dental or a dentist doing it. And I think in some conversation, I also came to know that when our dental therapists are taking the licensing exam, like ANEX or any other regional exam, I have heard that, and Dr. Self can maybe testify, I know that the examiners are blinded, so you wouldn't even, you can't tell whether I am a dental therapist taking the licensing exam or I am a dentist taking the licensing exam. I feel like those exams are really like very competitive, and you really need to be competent to get through the exam. And if the examiners are blinded, I think that is one way to ensure that dental therapists, we are not just talking about cost effectiveness, but we are ensuring that the quality of care is comparable with that of a dentist. But it is all about team-based care, and it is all about collaboration. So we hope that the lessons that we have learned from our project and all the work that our research stakeholder group has done and all the information we have shared today is useful to Maryland, and we'll be happy to answer any questions at this time. Or Nitika and Dr. Self, do you want to add anything to my presentation or anything else that I missed out? Okay.
No, thanks. I think you covered it.
Oh, thank you all.
Happy to take questions.
Oh, I'm sorry. Thank you all so much. That was very informative. We have one additional speaker, so I'd like to wait until everyone, all of you all have presented before we ask questions. We have Dr. Grover. Dr. Grover, I already introduced you, so everyone knows who you are. So we're ready for you.
Great, thank you very much. And I sent my PowerPoint to the good folks there. So if you could pull that up. I'm not able to share my screen. It says host disabled participant screen sharing. But what I'd like to open with is the fact that this program has graduates in 48 states. The beauty of this program is it doesn't need a change to the Practice Act. It doesn't need taxpayer dollars. It doesn't need a new building. It doesn't need a new equipment. This is a skill set of a community health worker for a dental professional, an assistant or a hygienist. Again, there's no change to a Practice Act, but it is an extremely valuable curriculum. And I would like to, if you could go to the next slide, please. The ADA developed this curriculum years ago when, in noting what the Journal of the American Medical Association had to say, is that patients need help with their social problems. The value of community health workers is well known in the medical world. In the dental world, well, we hand people a sheet of paper and we say, here, call one of these numbers. How many empty clinics? How many empty chairs? How many broken appointments are there? How much wasted time is spent from a patient trying to navigate their way to a community clinic that they didn't know existed? This program provides that essential linkage between a delivery site and the patient population. Next slide, please. And so identifying social needs is what's critical. And also a recognition of the social determinants of health. Next slide, please. Why is this important? It is important, number one, because the marketplace is demanding this. The marketplace is demanding, in particular, we've seen an uptick of the marketplace demanding community health workers with dental knowledge. We have calls, we see job postings for a community health worker with a dental skill set. And the US Bureau of Labor Statistics talks about the value of navigators. Next slide, please. Driving the demand. is improving health outcomes. It's not about giving procedures, not about doing procedures. It is about reducing healthcare costs. And part of that is connecting people to care that they don't know is available. 12 years at a community health center, and I would have people walk in every day and say, oh, I didn't even know a clinic was here. I went to the hospital emergency department. Next slide, please. So connecting people to care is what community dental health coordinators do. They take the competencies of a community health worker and they improve continuity of care, address social determinants, improve health literacy, and identify client barriers. Next slide, please. So CDHCs do what community health workers do. And this program is 8 to 11 months. The modules are online. Next slide, please. But it is not a self-taught program. In fact, the established value of community health workers was done in a special report by the Center for Healthcare Strategies. So we get continued reassurance that this skill set is valuable. Next slide, please. So that was the question that the ADA asked many years ago. What if a dental professional had community health worker skills? Next slide, please. So CDHCs, again, practice within the State Practice Act, no taxpayer dollars, no new equipment, no expansion of facilities that aren't operating at full capacity anyway. And from the health center world, I can tell you that that's true. The tuition varies according to the educational institution. Next slide, please. CDHCs are supervised by dentists directly or indirectly as their state law allows. It is the community health worker skill set and the dental knowledge base, which has leveraged this into a much higher profile, not only within community settings, but within private practices and hospital settings as well. Next slide, please. Online modules supplemented by Zoom sessions. It is a balance between clinical delivery and community prevention, community oral health promotion. Next slide, please. Points to remember again, no change to a practice act, and it can be stacked or offered as a continuing educational program in either a dental assisting or dental hygiene program. Next slide, please. Time commitment, it is a 3 to 4 hours per week of reading or a demonstration project. Community demonstration project is part of this. Some of those community demonstration projects have turned into HRSA grants. Next slide, please. Certificate of completion. Again, it is not a license. It is not a change to a practice act. The simplicity, the beauty of this medallion is affixed because the material is trademarked. And we've got community colleges offering this. Next slide, please. We have a community health center, which is offering this. We now see job descriptions in community health centers. Why is that? Empty chair time, broken appointments are expensive, and it is a waste of resources to not effectively connect patients who need care to the care that's available that they don't know about or have trouble getting to. Next slide, please. The Tennessee update, you can see that 3 dental assistants that had CDHC training linked 1,137 seniors to care in 8 weeks. This program received a $60 million grant. That's $60 million grant to get seniors into care. And obviously in 8 weeks, they did just that. Next slide, please. Healthcare and hospitals, decrease in the no-show rate. Next slide, please. Training sites, we're extremely excited to share with you all today that not only is this program being offered through a variety of community colleges across the country, but NFQHC in New Jersey launched it in the fall. A dental school, University of West Virginia, has integrated the CDHC training program within their in-house RDH, their hygiene program. We've got trainees within hospital settings. We've got case management code reimbursement. And I'm extremely excited to share with you that the Indian Health Service has inked in the licensing agreement. They will be launching CDHC in the fall. Next slide, please. And they have almost 3,000 dental assistants and dental hygienists. Internship examples, which grew into more, again, in 48 states. we have nearly 800 graduates with double that amount expected by this time next year. Next slide, please. Tooth Buds, here is a nonprofit which was launched by a CDHC grad. Tremendous program. Next slide, please. And you can see the difference that she saw in her first year, a decrease of almost 40% of children with decay. Next slide, please. Alabama Internship, University of Alabama School of Dentistry, teaching dental students to be more comfortable with very young children. This was a HRSA grant. This was also a research article published in the Journal of Dental Education. Next slide, please. Internship reflection. So for those who say, oh, we already teach that, we invite them to read some of the internship reflections. These are seasoned hygienists and assistants who have completed programs, but took the CDHC curriculum and were surprised by how relevant it was and by the skill set that they acquired. Next slide, please. Program value, next slide. In a graduate words, going to patients where they are at, otherwise they would never receive services. They'd never get that connection. Next slide, please. Gave me a broader perspective, a closer view, a deeper understanding of motivational interviewing and health literacy. Next slide, please. Valuable for newer or more experienced hygienists. And in particular, again, we see an uptick in job descriptions for dental professionals such as hygienists who are morphing out of clinical care and love to have this skill set because it offers them job utility. Next slide, please. A lot of information. Again, the curriculum is licensed and trademarked. It is offered to an educational institution at no charge. It is a licensing agreement because the material is trademarked. And between several community colleges, a health center, a dental school, and an Indian Health Service partnership, we're excited to see this program continue to grow. No taxpayer dollars, no change to a state practice act. Thank you.
Thank you, Dr. Grover, for that presentation. So I'm sure there are many questions. We've seen two completely different types of models. And so I'd like to take privilege and start with the first question. So in Maryland, we have a very diverse geographical state. We have Western Maryland, we have a very rural, very urban area, and then we have the Eastern Shore. So how do these programs help access where we have shortages of dentists in these in Western Maryland and Eastern Maryland? Okay, whoever would like to begin.
I can offer an answer, and I'll offer it based on the Eastern Shore. There was a dental director that did a pilot program with us a few years ago, seasoned dental director of a FQHC that has multiple locations. And he said, okay, I'll try it. I will take a CDHC and I will have her for 5 weeks and I will let you know what I think. And in 72 hours, he called me back and he said, I thought we were doing outreach. I thought we had a good footprint in the community. I'm not letting her go home and I want more of these people. This is the impact that CDHCs have, and I'll let the others answer.
I can add to that. So in Minnesota, we do have SEAL Minnesota. That's our school-based program for sealants. So we've seen our partner clinics utilize advanced dental therapists to go out and place sealant. And we also have seen many of our providers, especially working with Head Start in rural areas where there's always shortage of providers. And in Minnesota, 50% of our counties are dental professional shortage areas. So we do see that using dental therapists, especially in Head Start areas, and we do have different kinds of grants where we are focusing on using dental therapists, even for our basic screening survey, which is our open mouth assessment. So from surveillance to moving more upstream, I've seen the impact and success stories of dental therapy improving access to care, specifically in Greater Minnesota. Maybe Dr. Self or Nitika, you'd like to add to that?
Yeah, I would like to. And again, I think I'd like to make sure we all understand and appreciate these are two very different models, but they don't have to be in conflict with each other. I was the director of an FQHC clinic in Minneapolis, for 6 years, and I worked a lot with community health workers, and I'm a strong supporter of the concept of community health workers. And that's important to help with the efficiency of operations of a clinic and to get patients in connected to providers. But if there are no providers to provide the care, I was just up 3 hours north of the Twin Cities in an area where back 20 years ago, they had 20 dentists in that community. There's now 8. They do not have the people power to get all of the care provided to the folks in their community. There are 4 dental therapists up in that area now, and they just talk about how much more they can do from an efficiency standpoint as an office, how it's not 1 provider plus 1 provider equals 2 providers. It allows for more patients to be seen. So both strategies can work together. It does not have to be competition. You need to focus on what are your issues, and if lack of workforce is a problem, you need to get people to provide care. If getting access for people who don't understand how to do that, then you can utilize folks to get people into the office. That's my perspective.
Right, and that sums it up when we are thinking of dental home concept. So it's not either or, but it's all team-based care, and that's what we are focusing here in Minnesota, like more of the dental home approach for our patients or community members.
I'll just add that I don't know that it's the responsibility or the onus falls on one particular provider type to solve the state's dental access and workforce issues. I do think it's frameworks like scope of practice laws. It's bringing care to the people. It's increasing access so folks can get care where they need it. We also have a collaborative practice dental hygienist model to get the hygienists out in the communities and out of the brick and mortar clinics to bring the care to folks where they are at, in schools and church basements and libraries, even if you can stand an operatory there. So I think it's just a different mindset. I don't know that one particular provider type really is a solution for any state, given the myriad of problems we're all facing.
I see Dr. Verma's hand up.
Thank you, Dr. Hughes. Thank you, everyone, for the presentation. Just from the state standpoint, I'm curious if you could expand upon the 2 levels of dental therapy and the education required for both of those levels, as well as what the requirements are for licensure and the renewal timeframe.
Yes, as far as the 2 levels go, and again, Minnesota was the first state to pass legislation. And so there are things in our statutes that haven't necessarily been replicated by states who've passed laws in the past. In the future, passed after we did. But again, to be licensed as a dental therapist in the state of Minnesota, you have to complete an educational program that has either been approved by the Minnesota Board of Dentistry or CODA accredited. CODA did not have accrediting guidelines when we first started, so that's why the Board of Dentistry approval was an option. Again, that requires the program approval. You have to take a regional licensing exam, just like a dentist candidate, just like a dental hygiene candidate. In Minnesota, the one that's currently providing that care is CDCA, and I believe they do testing in Maryland as well. And after passing that exam, of course, you have to pass an exam on the laws of the state, pay your fee, and you can be licensed. Once you're licensed and actually practicing, if you have additional education at the master's level and 2,000 hours of practice as a licensed dental therapist, you go through this accreditation process, and the accreditation process is managed by our Board of Dentistry, and they look at submitted cases, documents, cases of patient care to assess that you're providing care competently. They have an additional exam that they give to assess your ability to practice at the advanced dental therapy level, and then they have an interview process. So it is quite rigorous, but it has led to, again, our state feeling very comfortable with the quality of care provided by dental therapists and advanced dental therapists.
Dr. Hughes, may I ask a follow-up question?
Absolutely.
Thank you, Dr. Self. Just out of curiosity, the CODA accredited program initially for the dental therapist to get licensed initially, how long is the program?
So CODA requires that you have 3 years of dental therapy education. That has been interpreted to mean 2 semesters in a given year, so 6 semesters of education. Our program is actually 8 semesters in length. And again, because of a quirk in our law, a dental therapist isn't allowed to do a prophylaxis. So our program is a dual degree program where they get a bachelor's of science in dental hygiene and then a master's degree in dental therapy, which allows them to use both scopes of practice, and it meets the needs of the practitioners in the community. And we anticipate that it will meet CODA approval. We have a site visit later this year.
I see Ms. Fitzgerald has her hand raised.
Hi, thank you. Dr. Fitzgerald, I'm the chair of the new dentist
I'm
committee, but I'm
sorry.
also one of the vice. Oh, no, totally okay, Dr. Hughes. I know I'm very young. But I am the Legislative Affairs Committee member, vice chair for the Maryland State Dental Association. And I had a question about what the cost was for that 4-year program, especially since I can speak firsthand to how expensive dental school is. And this is obviously cost is a big consideration for programs. Thank you.
If you're talking about our dental therapy program at the U of M, it's actually 32 months. So it's 3 years because we're year round. We go through the summer. And we give estimates in state tuition for program completion. And that's somewhere in the neighborhood now of between $85,000 and $90,000 total for program completion. The other programs in our state are programs that target licensed dental hygienists and provide them the education to become licensed dental therapists. I can't speak for them 100%, but I have heard them say, at least one of the programs at that cost is more like 35 to maybe 40,000 for them.
Dr. Corman.
Thanks for taking my question. I had a question when it comes to access to care and the impact that it's had in Minnesota. Because when I look at the state statistics and the dashboard as far as access to care for adults and children in total, in all the counties, basically, Minnesota's operating at still like around 35% access to care, even with dental therapists. And, in Maryland, we operate around 70% utilization and access to care. And so I guess my question is where do you see that the impact or the benefit has been? Because the numbers still seem really low to me. And where you would see the benefit in a program like in Maryland when we're already doing upwards of 70% as far as our access to care numbers and where that impact would fall.
So I look at this in a couple of different ways. And you have to remember when our legislation was passed, roughly 80% of the dentists in the state of Minnesota did not approve of dental therapy. It has been something on a national level where organized dentistry has, for whatever reason, not been real supportive of it. And so we started off slow with producing dental therapists because you have to have dentists to work with them. We're at a stage now, as I mentioned, we have more dentists looking for therapists than are available. So we could start to increase our numbers. It's a supply and demand thing. We're in this for the long term. It's not necessarily a quick fix. And so, yes, 120 dental therapists compared to 3,500 dentists. You're not going to see rises in population numbers. But in the communities where the dental therapists are practicing, that's where they're making a difference. Again, these are communities that have provider shortages. They're communities where there may be one practice that accepts Medicaid patients, and they weren't open to new patients until they were able to hire a dental therapist. Then it allowed them to open their practice more again. So it is a little challenging to share what all of our benefits are. I do know, though, that I was talking with a dentist in Minneapolis whose 80 to 85% medical assistance patients focuses on our Somali population. And he basically said that their practice could not go back to practicing without a dental therapist because of the way they've structured their office and increased their access with people coming in because of the division of care. So it is making a difference. I think in a state like Maryland, it depends on if there's support for it. The support grows over time because as the dentists hear their colleagues talk about the benefits of it, there's more and more interest and excitement. If the Maryland Dental Association would be open to supporting it, I think you could find that you could grow the program fairly quickly and get people out into those areas where you need additional workforce. That's just my 2 cents worth.
So then to just piggyback off of that, because right now, like University of Minnesota produce, I believe, 7 dental therapists in a graduating class right now, correct?
But we have different targets based on space, but 7, 8 have been consistent.
So what my question is though, and as you talk about ramping up a dental therapy program, have you guys looked at what the impact that's going to have on graduating dentists that are also coming out now competing? My worry is a little bit, and I'm just wondering if anybody's looked at when it becomes 30, 40 people that are graduating from a dental therapy program, do they then begin to compete for the same jobs that dental students that are graduating from a 4-year program are also trying to compete for?
Well, again, I don't know the demographics of the dentist in Maryland, but we have dentists every day who are retiring and closing their practice because there's no dentist available to buy it. We are not lacking for opportunities for our dental graduates, and I would really not envision that doubling, tripling the size of our dental therapy class would impact that, because a dental therapist can't buy a practice. Only a dentist can own a practice, and the dental therapist works in collaboration with the dentist under the supervision of a dentist. It's collaboration, not competition.
And it's almost like for a dental therapist to be viable, a dentist has to be a president.
No, I know, and I guess I don't want to come off as being argumentative, but I'm a pediatric dentist, and I work with a lot of DSOs. I'm not in a DSO, but I work with a lot of DSOs, and I understand the dental therapy model is a little bit geared more towards children. I mean, meaning they treat more children. And if I do own my practice. We see a lot of Medicaid in my practice. And if I was looking at it and saying, well, I could pay, for a pediatric dentist coming out of residency to come work with me, or I could hire 3 dental therapists for the same cost, it becomes a little bit of, if we're talking about numbers game, it becomes a little bit that I begin to worry about what happens to all these people that are going into residency programs, things like that. And all of a sudden it's kind of like, if these larger organizations, people saying like, well, I mean, dental therapists are doing the bulk of the work. I mean, I really don't need that there. It's just a not ethical, but it's just a situation that kind of goes in my mind. If I'm looking 10 years down the road or 15 years down the road, what that model looks like. And I'm just posing the question, that's all.
Sure. And just, kind of as a reminder, the dental therapist has a limited scope of practice. So for a pediatric provider, I know we have tough time getting all of our kids who need OR care served, and having additional residents focusing on that, could be a positive as well. It's a different mindset. You have to look at the world differently. But 50 years ago, every dentist did their own hygiene work. And you look at that today, and there are very few dentists out there that are doing dental hygiene. And that did not decrease the demand for dentists. And in some senses, it increased the demand because they were able to get more folks in who they could do exams on and find care. So I know it's not apples to apples. I'm just sharing that it's a different mindset in how you look at providing care.
Dr. Verma.
Thank you so much. I have a question about the collaborative agreements and how the liability for those work. The collaborative agreement is made with the dentist, so I'd like to understand where the liability is. Is the dental therapist held accountable by the state boards, or who covers the malpractice, that type of stuff?
Well, yes, a dental therapist could be held accountable if they are found to have violated things. They are a licensed provider. But as a practice owner, a dentist also has responsibility for things that occur within their office. If there's a problem with care provided by a dental hygienist, yes, the hygienist is a licensed provider. They would have disciplinary action, but if there's legal action, potentially they could go after the dentist or anybody else in the office. There is liability insurance available for dental therapists. It's at a very low cost because, to date, there hasn't been any exposure from the insurance companies from a liability standpoint. So that's our experience.
So is the dentist also covering, does the dentist malpractice designed to cover the dental therapist as well?
Yeah, their office policy will cover the care provided by a dental therapist. Yes.
Thank you.
I have a question about the CDHC program. How are they reimbursed, and are their services reimbursable through Medicaid in most of the states where they exist? Is Dr. Grover on?
I believe she's dropped off the call.
Oh, okay. Well, so let me ask a salary question regarding the dental therapist. What is the salary range, and how is that determined?
Salary is one of those issues. And I'm going to do this in a little bit of a perspective, because the salary for a dentist in Minnesota is different than the salary of a dentist in Maryland. The salary of a dentist, in a rural area may be different than it is in an urban area. When we did some initial look at that, we saw that, for an office to have some parity, a dental therapist would make somewhere between 50 and 65% of what a dentist makes. We have done some surveys. Unfortunately, people giving salary information hasn't been very popular, so we don't have large numbers to consistently compare. But we are finding that in practice, that is typically the case, although once folks achieve certification as an advanced dental therapist and they can provide care under general supervision, and oftentimes in settings where a dentist isn't present, they often wind up being on the higher end of that scale, and that's what we're finding.
Okay, Dr. Fitzgerald.
How many applications do you receive per year for the programs? I know you can probably only speak towards University of Minnesota.
I can only talk about the University of Minnesota, and we're consistently, 28 to 35 applications for our, and like now eight is going to be our target moving forward, to try and, again, get a few more dental therapists in there. Out of that, we usually interview somewhere around 18 to 20 of them. If you were interested or cared, to the qualifications of our students, the average GPA of our admitted folks is a 3.39. And for our prerequisites, which are the same as dental hygiene student prerequisites, our average GPA is 3.58. So we have very high qualified individuals who are applying and coming to us because of their desire to focus on the mission of dental therapy. And it's not the traditional students. In our class, the last class we took this past fall, we did accept 7. And we had 4 of those 7 identified as racially, ethnically diverse, and 5 of the 7 were first generation college students. So we really are looking to attract people from diverse communities and underserved communities because that's the best predictor for them to go back and serve in those areas.
Okay, I don't see any other hands raised.
I have one question.
Oh, I'm sorry, I didn't.
Ricardo Kimbers here
Yes.
in Baltimore. For Dr. Self, what differentiates the patient, the person that wants to go into that profession versus going into hygiene or going into being a dental assistant? They're kind of different, but one and the same in aspect of being under the supervision of a dentist. So what's the niche that causes someone to be a dental therapist?
Yeah, with 120 licensed dental therapists, we probably have 120 different stories. We used to highlight that with a lot of our folks, but some commonalities that I can speak to is a number of these individuals, because they are first generation students, ethnically diverse, they have never envisioned themselves being a dentist. They did not grow up with that aspiration, but they did grow up with an aspiration of helping people, being in healthcare. And when they find that they can have a professional opportunity that works, with folks like themselves that, do something positive, that really motivates a lot of folks. And so we have a number of people who make career changes, people who were teachers, people who were, some other kind of thing. And then they decided they wanted to get into healthcare and they didn't want to invest in both the time and the dollars that it takes to become a dentist. We have a few people who had considered being a hygienist and then heard about dental therapy and decided that they wanted to, do a little bit more. And we have had dental assistants who worked in a dental office for a couple of years, and they recognized, and their dentists recognized, they had more capabilities to share, and some of them actually pay for them to come to our program so they can go back and become dental therapists in their office.
Thank you for that. We appreciate your time and your presentations. You've given us a lot to think about. And if we have any follow-up questions, is it okay to send those to you?
Absolutely.
Great. Thank you so much. So now I'd like to give our committee time to give their presentation to the elderly committee.
Thank you, Dr. Hughes. I will ask Lindsay to bring up our presentation. Dr. Charlie Doring is not with us today. He is traveling in Scotland with his family. So we wish him a happy trip And I'm pleased to talk to you today about the findings of our senior population task force. So Lindsay, if you could go with the next slide. As we were asked, we were charged with coming forward with three things to set up seniors and all of our committees for success: the population needs, the access issues, and the suggested solutions. So we'll jump right into those. Thanks. You could go right to the next one, Lindsay. So again, to refresh everyone's memory, the senior population of Maryland totals about 626,000 people. We said how about 9% of that population is living at or below the federal poverty level. And what I wanted to make known here is that 9% who are on Medicaid and Medicare both are going to be covered under the new adult dental Medicaid program. So I would just repeat that, this Medicaid program will cover people above 65. It's about 9% of this population. And the interesting thing is, as you see below, is that about 4%, a little higher, of our seniors live in nursing homes, and 2 live in assisted living facilities, while the majority are out in the community. But know that of those that are in long-term care facilities and nursing homes, 61% of those folks, those seniors over 65, are on Medicaid as well. So they will be covered under our new system, right? Under the new adult dental Medicaid program. The thing we need to get better on, though, is that 65% of Maryland seniors do not have dental insurance. Next slide, please. So this is just a person that came into my office, Paul. Paul does not have dental insurance. He's 72 years old. He came into my office because his tooth broke on the bottom. He hadn't been in the office about 10 years since he retired and lost his insurance. When we took this Panorex, what did we notice? He has a carotid artery issue here. He has a clog in his carotid artery. What happened? Our community dental health worker referred him to his primary care physician, and later he ended up having a carotid stent put in, right? So what's so important is that dental care is a window for seniors to be healthy, to have health care. And we see this time and time again. Of course, this is an issue where many seniors who don't have care, as we know, go to the ER. If you could do the next slide, please. So to remind the group, the biggest cohort population growing of age group going to emergency departments for dental care are those seniors who are 65 and older. And many of those seniors that show up at the emergency department are pretty sick, right? They don't go unless there are some really bad things happening. And so I want to really show the group and remind the group here of all of us gathered on the task force that all of our age groups are going down in emergency room visits, but seniors are increasing. Okay, the next slide, please. Of course, it's all about the mouth is connected to the body. And as Surgeon General C. Everett Koop said, we can't be healthy without oral health. So that's really what the population needs, is the opportunity for health. Not to mention all the chronic diseases that dental providers can provide care and access to. We do a lot of sleep apnea kind of treatments in our office. The example that I showed you, diabetic care, the list goes on and on. The next slide, please. What our senior population needs through their dental care is really access to periodontal therapy and preventive dental care, coaching on tobacco and nicotine elimination, coaching on eating less sugar, consuming a healthier diet, managing their medications to maintain normal levels of saliva. They need us to help them replace their missing teeth so they can eat proper, healthy foods and smile and communicate and interact. We need to help them to treat infections, to support their immune system, and also do screenings for the chronic diseases such as oral cancer, diabetes, everything. We can go on and on. So the next population need, next slide, please, Lindsay. What these kind of human needs translated to as far as how do we actually make this happen is seniors need better dental insurance. They need coverage for overall health, including diagnostic, preventive, silver diamine fluoride, restorative, surgical, and prosthetic care to replace the teeth that they have missing. And just as a reminder, we know that those prostheses are not included, for example, under the new adult dental Medicaid program for seniors in nursing homes and long-term care facilities that often lose their dentures. So that's something we could get better on. We need to educate seniors on the importance of regular oral exams, even when they don't have teeth. I've had very intelligent seniors come to my office with what they thought was a denture lesion, but it was actually a oral squamous cell carcinoma, and they died shortly thereafter. So they need to know that they need to come to the dentist to really support their overall health, even if they don't have teeth. We need to coordinate with long-term care, nursing homes, healthcare providers, and caregivers to ensure oral health care is in place and accessible. And finally, we need to really make sure that our workforce is trained in delivering care to the complex senior patient, which I know from experience with the medications that seniors take can be complex, and it takes the skill level of a dentist to treat. Okay, next slide, please. So the access issues. Our Maryland Oral Health Task Force was charged, as were all of our work groups, to look at this column on the left, right? These top barriers impacting Maryland seniors are also barriers that affect pediatric patients and Medicaid patients and all of our subgroups. So here they are: socioeconomic, insurance, geography, racial, ethnic, practitioner workforce, and education. But what our group, our senior group found was interesting is how much these issues that we were kind of tasked with overlap actual top reasons given by nearly 15,000 adults per the American Dental Association Health Policy Institute as to why they don't go to the dentist. Cost being number one, right? So as Marco Vujicic at the AD Health Policy Institute said, dental care prevents the highest level of financial barriers compared to all other types of healthcare. Fear of the dentist is a big one. Next, we have inconvenient appointments, this type of realization, trouble finding a dentist with their insurance. One of the biggest ones we find is people seeing no perceived need, right? And that is something where education really comes in to help seniors to understand that just because they feel like nothing's wrong doesn't mean that that's the actual state. They need regular oral exams to ensure their health. Okay, the next slide, please. So just as a review with insurance coverage, still today, only 34% of people know that most dental care is not included in Medicare. That's still a barrier for some seniors. They really feel like there is some dental coverage. So that's something that daily, and I know in my practice, we have to explain. Medicaid beneficiaries have 3 times the emergency department visits as non-Medicaid beneficiaries, commercially insured patients here. The 65 and older population is the least likely cohort to be covered by private dental insurance. And finally, and I want to point out to you, the last point was actually researched at the University of Maryland by Dr. Mansky, Dr. Reed, and our prior state dental director, Dr. Goodman. So those with dental insurance are 2.5 times more likely to make a regular visit compared to those without. And as a dentist here in rural Western Maryland, I hear and see that every day. People don't have insurance, they don't go to the dentist. They get insurance, they go to the dentist. We need to get better at providing access through helping more seniors to have dental insurance. The next slide, please. This is a detailed look on Maryland adult dental Medicaid by age. And again, to just get a little more granular about the impact of the adult dental Medicaid program on seniors, there are about 57,446 seniors that are going to get the adult program. So that I was really pleased to hear. And I think it's something that is going to have us really as a dental community be ready, because a lot of these folks are coming out of long-term care and nursing homes. We have to be ready to treat them well. Okay. Next slide, please. Again, to get even more granular on the access issue of dental insurance, which by survey cost is the biggest issue, is that only 13% of Maryland seniors who are on Medicare have a dental benefit through Medicare Advantage or Medicare Part C. To review with you again, in Maryland, there is very little Medicare Part C available. As I inquired about that and asked, I think it has a bit to do with how our all-payer system is, where be you commercial, Medicaid, Medicare, or private, you're paying the same at hospitals. In many states, this number is much higher, like as high as 28%. So I think it's an area that we could do better. One thing the senior committee wants to stress is that as part of our solution, we can open up more Medicare Advantage dental programs to our senior population. The Maryland senior population has about 13% commercial policies. The new Medicaid program will cover about 9% of our senior population over 65. In Maryland, on the marketplace, you know, when you go and buy dental insurances on the marketplace, which people under 65 can do, once you hit Medicare age, you are not able to do that. So we would offer this as another area of opportunity. I think whenever Alex Shankdar was part of our group, he had mentioned this as a possibility too. So no dental insurance for seniors is sold on the Maryland Exchange. Uninsured Maryland seniors, about 64% do not have dental insurance, and 2% are our veterans and some of their families, which makes up about 2%, have TRICARE insurance. Okay, next slide. Senior access is affected by geography, as older adults in rural areas are more likely to report a functional problem or rate their health as poor. They need access to care. Next slide, please. Also, racial, ethnic. We see that 33.5% of seniors living below the poverty line have untreated dental caries compared to only 7% of high income seniors, right? So an economic disparity. Racial disparities as well. Higher rates of untreated caries in Hispanic and Black seniors compared to non-Hispanic white seniors. Next slide, please. So how would eliminating these barriers make an impact on access to dental care for Maryland seniors? How would that influence their health outcomes? And as our group kind of brainstormed, these are what we figured we'd accomplish with that. We'd reduce suffering. We'd improve their health outcomes. We'd close care gaps and coverages. We'd definitely lower the cost of chronic disease management. And the ADI HPI shows us that. Many studies about diabetic care and how that lowers whenever people have access to preventive dental care, to dental cleanings, periodontal treatment. It would decrease opioid use. You know, seniors definitely increased in their opioid prescribing by dentists during the pandemic. I also serve on the prescription drug monitoring program, technical advisory committee as the dental advisor. And so I do believe that with improved access to dental care, we can control opioid prescribing better for seniors, lower health disparities, increase health equity, improve quality of life, and help people live longer. The next slide, please. So what are our suggested solutions to review? First of all, to increase the percent of Maryland seniors who have a dental benefit. As we said, nearly 65% don't. We can do better than that. Secondly, add benefits to the Maryland Health Exchange for seniors to purchase. Some seniors, they'll come into the office all the time and say, well, I'd like to buy dental insurance, but I'm just not sure what to do. I mean, this is where we have our community dental health worker come and help, look at the programs offered by various kind of outside organizations. But I really think if it was on the exchange and somehow made reasonably priced, a lot of seniors would be able to afford their own insurance, and that would be big. Third, expand Medicare Part C dental options, especially into counties where they aren't available. In my county of Allegheny, you cannot get onto Medicare Part C. It doesn't exist. It's just being rolled out in some of the bigger counties like Montgomery County, Prince George's County. So we need better equity and access to Medicare Part C, which often has a buy-up to a dental benefit. Fourth, adding Medicaid coverage, specifically, as we talked about how 61% of seniors in long-term care have Medicaid, let's be ready to replace those dentures, those partials, those prosthetics. So let's make sure that we're having coverage for prosthetics for seniors. One thing we could do is for the children's program, as I understand it, the eligibility is at 400% and below the federal poverty level. Maybe we could do something like that for seniors in Maryland. Maybe we can make higher the threshold of the federal poverty level for a senior to be able to receive the adult dental benefit. Mind you, 133% of the federal poverty level is about $16,000 per individual. So it's not very much money. Sixth, develop policy on the importance of oral health to caregivers and health professionals. More and more I see, before a senior gets surgery, they want to have, they come into the office because their physician knows that before their hip replacement, they need to make sure they have a dental exam. If they don't have dental insurance, sometimes they get kind of worried about that. But increasing our communication to other healthcare providers to really remind them that we're all on the same team, all with patient health overall in mind, and the part of oral health in making sure that that is the case. The next page. So there's something called an incurred medical expense that can be used for seniors on Medicaid. It's used in long-term care facilities where utilizing the facilities at the long-term care facility or nursing home, there is a way to bill Medicaid for certain things. The ADA has more information about this. It's not very used in Maryland, but it could be a way to maybe, as we're trying to put prosthetics in our Medicaid program, that there's a workaround or some way to get these folks help that need prosthetics and are on Medicaid. Okay, the next one. Other suggested solutions by policy are proper education on the importance of good oral home care, customized to patient needs. Like we said, promoting education programs that encourage dentistry in non-traditional settings. I know our community dental health workers here are going down to the Juneteenth celebration, and passing out toothbrushes and doing things like that. So how can we go ahead and engage with people in the community and then go ahead and in places like senior daycare centers, nursing homes, and for homebound, make creative solutions to grant people access to care. Promoting the use of telemedicine is something that we see being definitely a thing that we could take advantage of to be able to help seniors. Mandate that long-term care facilities have a dentist on their medical staff, and that comprehensive oral exams are to be done on the residents of those facilities at least annually. Finally, to encourage our dental community to become more versed on taking care of geriatric patients, of seniors, and developing programs for community dental health coordinators to help patients and family members to better navigate the system. So that's what I have. And it was a pleasure working with Dr. Doring And we are happy to take any questions.
Thank you so much, Dr. Romaine, for that well thought out and, you know, the research, the suggestions, and you really have given guidance for the other committees on how it should be done. And I appreciate that.
Thank you.
Are there any questions? So no questions. Well, what we will, so this information will be now used for comments as we, you know, will take these suggestions to see how we want to move them forward. So thank you again so much. We really appreciate it.
You're welcome.
Dr. Reynolds, do you have anything you'd like?
No, other than I agree, it was an excellent presentation. I would like, you know, to ask, and this is really policy, so I don't know the process, but your suggestion, for example, the ACA marketplaces, allowing seniors to be eligible to purchase dental benefits, what that type of recommendation would entail on the state level.
You know, I don't know, is Delegate Bagnall able to answer that, or can you help us with that? I mean, I don't really know the process of how we would go about doing that. Is that something that you're familiar with?
I would actually need to do a little digging. So I don't want to give a wrong answer in situ.
Yeah.
Thank you. Yeah, I think it's an excellent suggestion. I don't know what the implications are budgetarily, if any, or if it's just a matter of how the licensing agreements are established within the state.
Any other comments? So our next steps, we will, at our next meeting, which is scheduled for, I'm sorry, Lindsay, can you help me out there?
The next meeting is July 21st, Thursday again. That meeting will be 10 a.m. to noon.
Thank you. So at that meeting, we have scheduled speakers, and we will also continue with our subcommittees reports and recommendations. Any other announcements, anything anyone would like to say? Delegate Bagnall, is there anything you'd like to say to the group?
Well, I was actually just putting in the chat. I said I'll try to get clarification on that question before our next meeting. I will be. I'm going to ask my chief of staff to be my proxy on that one, because unfortunately, I'm not available. I work at a summer camp every year, and it's only 6 weeks, so for
very
6
nice.
weeks they kind of need me.
Yeah.
But I just want to thank everyone for continuing to move the needle, and also I'm glad to see we're starting to sort of think not just in big picture strategies, but about what that would look like in policy. And I really appreciate the speakers who have sort of brought us what that template could look like.
Great, thank you so much. So with nothing else, I guess we can adjourn for the evening. Thank you again, everyone.
Very good. Thank you. Take care.
Thank you, everyone. Have a nice evening.
You as well.